right. Well, welcome everyone to our noon call on kind of the everything update these days. And amazingly, it is the last day of August. So I hope everyone has a relaxing weekend planned. And we will, what's really kind of amazing to me is just still how there are new things all the time coming up with COVID and really everything else. So, all right, let's get started on just checking in on our COVID community levels really across the US. COVID community levels have, the levels of COVID in community have gone down. There's much more green on the map, and you can see that in our state as well, much less orange. So that is good news. And again, this is tracking really both the cases and hospitalizations. If we look at this map, which is really just looking at cases and percent positivity, you can see that there is still a lot of COVID out there. But what we're seeing is fewer hospitalizations and deaths, and that's partly because cases are actually going down, partly because we do have a good vaccine level in the state, and then lots of people have gotten COVID, and so have some natural immunity. And then we also do have medications that can help people stay out of the hospital. So that's why you can look at this map and go, it looks awful, and look at the other one and think that looks better than it has in a bunch of weeks. And it's partly because they are measuring two different things. So still a lot of COVID around, but more tools to deal with it, and fewer hospitalizations as a result of good vaccination and medications and natural immunity. So looking at this is the actual cases reported by week. So you can see that the trend here is downward after quite a lot of time in the yellow, but nothing compared to, or it looks like nothing compared to the beginning of Omicron here in February, well, in the early winter. And that, again, is partly because we don't report as many cases. But the good news is it's trending down. When we look at variants, we're still seeing BA.5 really across the country, and definitely in our region of the US. We are also starting to see creeping in a BA 4.6, which is something to keep an eye on. We don't really know whether that's something that's going to outcompete BA.5 or whether it's just kind of a little blip. And that looks like it's more in the upper Midwest. So we'll just track that in 2 weeks. We will know more. So children and COVID-19. So I think this is just for all of us working in COVID at the Department of Health, it just, and really across the state, it is discouraging our low vaccination rates in children, especially as kids are getting back to school. It would be great to see more vaccination. I think out there is still that narrative, it's mild in kids, why should we bother getting vaccinated? So this really shows that kids did, there are a lot of cases in children. And again, in kind of the more recent, when looking at the more recent number of cases, we know that a lot of cases are unreported because they're home, kids are getting tested at home as adults are, and it's awesome that that's happening. But just to keep in mind, like you sort of have to double or triple the number of cases that you see on any graph currently. So for children ages 6 months to 4 years, this is the group that is least vaccinated. They were approved not that long ago, but only 6.7% have gotten the 1 dose. And again, for Moderna, it is a 2-dose series, and for Pfizer, it's a 3-dose series in this age group. And then only 1.7 have completed that full primary series.
Ahí voy a dejarte la comida, pero
Really
tengo...
low. For children ages 5 to 11, it is a little better, but basically 41% have gotten at least 1 dose and 33% have completed the primary series. So looking at the weekly vaccinations for kids 6 months to 4 years old, they're low, and basically this is looking at US data, but our data in New Mexico mirrors that as well. So this is weekly vaccinations for ages 5 to 11. The vaccine has been available to this age group for longer, but you can see, like, here's the enthusiastic parents, the early adopters, and then it kind of trickles off from there. So really trying to talk with parents and reassure them that, you know, the vaccine side effects in children are really mild. It's been around, lots of kids have been vaccinated, and definitely no big safety signals have come up about COVID vaccine in children. So, you know, just like adults, sometimes pain in the arm, sometimes some swollen lymph nodes, kids get, you know, can have a little more irritability or crying, sleepiness, loss of appetite, fever, headache, muscle and joint pains, or chills. All are a possibility. Overall, you know, this hasn't been one that people have complained about. Like when we first had HPV, you know, the number of kids fainting because that one was so painful definitely like hit the news. It was very noticeable. And you know, other childhood vaccines also have side effects. Okay, Omicron booster. So this is on its way. The FDA just today did give the nod and approve the Omicron booster. It still is getting considered by the CDC or their subcommittee, the ACIP. And they are meeting tomorrow and Friday. So we should have full approval for this Omicron booster by the weekend. It's shipping out early next week if all the approvals like continue as we expect. And so by the end of the week, people will, you know, should be able to get vaccinated. So the new COVID, and so this is a new booster, and what's new about it is that it contains parts of the original vaccine as well as vaccine that's very specifically directed against Omicron subvariants BA4 and BA5. But the hope is that it really will protect across the spectrum of Omicron variants, and that's pretty much what we've seen since Thanksgiving. So like, yeah, getting to be close to, you know, 3/4 of a year. But when Omicron first came on the scene, and then all the variants we've dealt with since are basically offspring of the original Omicron. So let's see. So the other thing is you do have to finish your primary series with the original vaccines. This is not going to be a primary series vaccine. It's only going to be a booster. And both Pfizer and Moderna will have this bivalent booster that has original plus BA4, BA5, and really they are very interchangeable. So people should feel comfortable with a mix and match on that. Doesn't matter which one you get. So the new Pfizer booster is going to be for ages 12 and over. They are also working on a booster for younger kids, 6 months to 11 years. And probably that's going to be more like November, December when that one gets, you know, manufactured and approved. The new Moderna booster is going to be for ages 18 and older, or at least that's what they applied for approval for. So why get the new booster? Basically, you know, Omicron has been a bear. It really is more infectious. It continues to change and evolve, as we talked about, like kind of everything we've seen since Thanksgiving is Omicron. And there, is, it's interesting because people do talk about all respiratory viruses have a seasonal pattern. We haven't seen that so much with COVID, in that it's definitely not just in the winter that we see surges of COVID, but definitely the winter is tough because, you know, people go inside and spend more time inside, and so it just has more fertile ground for spreading. The hope is also that this new booster will provide protection that works better against, again, even if it's not exactly BA4 or BA5, that is the next variant that comes, that it'll provide protection across the Omicron spectrum. There is also hope that it will last a little bit longer. I'm not sure that's really proven to be true with this booster. I think they are working on boosters that will have that longer protection. So COVID home tests. Unfortunately, the federal government is not going to continue their home test ordering program. It ends this Friday. So as of yesterday, you could still order. I got on and placed an order, hoping they're going to come. And I would encourage everyone to do the same. But basically, they did not get funding for Congress. I think they have left the door open if they do get more funding to reinstate this program. But that is unfortunate. However, in, oh, this is the, yeah. So it will come off of our website as well as a choice. But in New Mexico, we do also have access to this program, Project ACT. It is also on our website, if you don't remember this link here, which is accesscovidtests.org. Or I always Google Project ACT, and that seems to do the trick. But this is another way to order home tests. This program will continue until out of tests. And right now we have a good supply. They get sent from Amazon, but you do not need to have an Amazon account. It's kind of like an Amazon community program, and the Rockefeller Foundation. But the state has paid for this program, and so it's nice that we have this backup. And that program will go through February of 2023, and then, I mean, hopefully it will extend, but for right now, that's as far as they've committed to. So moving on to monkeypox. So monkeypox does continue to increase. There's 25 cases in New Mexico. So it certainly has increased, but nothing like what we saw with COVID. This is US data. So this is the number of cases reported to the CDC by day. So there's still a fair number of cases being reported. And we do have vaccine, which is a good prevention strategy for monkeypox. We have, you know, a good amount, not enough for everyone to get vaccinated, and probably not everyone needs to be vaccinated. So really, people that are high risk for getting monkeypox are, you know, is the target audience. And monkeypox spreads through that direct skin-to-skin contact, which is often in the setting of sex. And the population that it's circulating in right now is largely men who have sex with men. Across the US, there are a few children and a few women who have been infected. But really what we encourage is people who to register by phone. And the advantage of registering by phone is you can really talk to someone about what your risk might be. For people who are just more sure about their risk or don't want to talk to someone, that is A-OK too. You can register online now for vaccine at monkeypoxnm.org. And again, the registration does kind of put you in a high, medium, or low risk. For high and medium risk, those people are getting invited for vaccine. For low risk people, they'll be just kind of on a waiting list until you know, we have more vaccine, or CDC recommends, you know, a wider scope for vaccine. So polio in the US, this is definitely something we have not thought about in years in the US. But a man from New York State was found to have polio in July of 2022. The patient hadn't traveled internationally, and so was thought to have actually been infected in the US. So previously, really the couple outbreaks or the couple cases that there have been in the US had all been related to international travel or direct exposure to the person who had traveled internationally. So this was really something different. They then did some investigating of wastewater and found that in this area of New York, Rockland, Orange County, and New York City, that it was showing up in the wastewater. So probably polio had been circulating some in those communities for a while. And I should say about polio that lots of, people can get polio that's essentially asymptomatic, and that's not really considered a case. It's considered a case when you get the more serious symptoms like the paralysis or trouble breathing. So that's why it didn't really come to light. And people who've been vaccinated can actually kind of get the polio virus. They may be pooping it out, and so it's showing up in the wastewater, but they're not actually affected by it. The thing is, those people can pass it on, not knowing, to other people. So if everyone's vaccinated, this really isn't a big issue. But when there's a group of people who haven't been vaccinated, then they're getting more serious cases of polio, and that's when it becomes an issue. So the best way to protect against polio is through vaccination. The vaccine we have in the US is inactivated poliovirus, which is given by injection. The oral polio vaccine is no longer available in the US, but is still given lots of places in the world. And that is a live virus vaccine that is given orally, obviously, as the name implies. And I think it was in about 2000 that it stopped being given in the US. So the polio vaccine has been required for children attending school and daycare centers, really across the US. Okay, next, something new, West Nile virus. And this is kind of an interesting one because it's very limited in where you find it in the US. It's basically in the couple states around us and Arkansas. Yeah, I did my medical training in upstate New York, and definitely not something I'd heard of until I moved out here. But it has been, every year they monitor the mosquito population. It did a couple weeks ago, was detected in the mosquito population in Albuquerque. But no human cases have been reported yet for this year. But every year there usually are a couple. There's sometimes a couple fatalities or deaths from West Nile. And one of the issues is that it can kind of cause a meningitis. Symptoms of West Nile virus: fever, headaches, body aches, vomiting, diarrhea, fatigue, skin rash. So it really can feel a lot like kind of a summer flu. And people can recover without treatment, but some people do get more serious cases and require hospitalization. So the main thing is protecting yourself from being bitten by mosquitoes. And so that's bug spray when you're going outdoors, trying to have screens on windows. And really the biggest thing is preventing that sitting water from around the house. So, if you have water barrels collecting rainwater, you want to make sure there's screens on top of that. Pools, the pet water bowls, bird baths, sometimes just like little drainage areas that collect water after it's rained or after if you're watering a lawn. So I think that takes us to the end. Thanks for all you do out there. And thanks, Liesl, for having a really cute dog picture in our slide deck. And I'm going to stop sharing. And yeah.
All right. Well, why don't we jump into our Q&A portion? So if you have any questions, feel free to raise your hand or type them in the chat. We do have one question in the chat already, which is, will everyone be eligible to get the latest booster?
Great question. So it is likely that let me just say, everyone 18 and over, yes. And then it is also likely, I'm not exactly sure what the CDC is going to do about that 12 to 17-year-old age group, because right now, if you got Moderna as a 12 to 17-year-old, there is no booster recommendation. But for Pfizer, there is. And the Pfizer product is going to be approved from 12 and up, and the Moderna product 18 and up. So we kind of have to wait to see what they say about the 12 to 17-year-old group, but I think it's pretty clear 18 and up will get approved. And it is possible that the FDA already said the answer, and I just haven't had a chance to read it yet this morning. So I think it was like 9 o'clock that we got something about their approval.
Ife, do you want to say your question?
Yes, I have two questions. One is concerning the new shot that's going to come out about when it will be available, and people who've already had their boosters, older population, immunocompromised, should they wait the 5 months that you're told before getting that shot? And my second one has to do with monkeypox. So I can hold that one, and if doctor wants to answer this one first.
Yeah, great questions. So what we understand is that this booster will be kind of, the main criteria will be that you're 2 months out, or it may be 3 months, but let's just, 2 months is what Pfizer said to us. So like, if you're 2 months from your last COVID shot, whatever that shot is, if that was your 5th dose, your 4th dose, your 2nd dose, the only thing is that it can't, you do have to have finished both doses of the mRNA. So it can't be the follow-up to your first shot. But so kind of no matter how many boosters you got or how many you missed and were supposed to get, this booster is going to kind of like wipe the slate clean, and everyone's going to be eligible for this booster. And it will be probably shorter than those other booster intervals that you're mentioning. Because yeah, we've had, like, every booster kind of has its own interval that you have to keep track of. This one's just going to be like, whatever that last shot is, 2 months, boom, you get the.
How long are they saying it will last?
So, it probably is going to be about the same. And, what we've seen is it's kind of 6 months. For some people, it seems like it wears off sooner. Some people a little bit longer. But overall, I mean, that's kind of what's in my head. At about 6 months, you're probably going to be vulnerable again.
Okay, thank you. Okay, my second question is, I don't even know if anybody can answer this, but I did attend the update that the World Health Organization WHO had this morning. I was quite troubled by it. They did not seem to be answering the questions that people were asking concerning monkeypox. And they did speak on some things that concerned me from the not last meeting, the meeting before. So they were saying that definitely it's been found in blood, semen, and some, of course, your other bodily fluids. However, they wouldn't answer the question as to, well, what happens when you have a bisexual man or woman who has sex with their partner, and then they've already been contaminated and they're going to pass it on, whether you're straight or gay or LGBTQ. That's the issue. And they did not answer that. And one person finally said, do we use the protocols that were put in place when we had the large outbreak of HIV? And tongue in cheek, one of the women doctors kind of said, well, I would think that way may be what we need to do, but they really don't seem to know a lot. And it's very concerning. So do we tell people to use safe sex practices, limit partners? What do you say to your clients?
Yeah, I think it is a hard one. And let me just start also by saying, like, I think it, like, a lot of the comparisons are good with HIV, but you know, HIV is a disease that you have for your life and can be deadly. And monkeypox is awful for 3 weeks or 4 weeks. It can be deadly, but rarely is. And so, you know, I think I also do just want to frame the conversation in saying these are two very different viruses, which I think you all know, but sometimes it is easy for it to just get like we're kind of talking about the same thing. And it has a much lower death rate even than COVID does. On the issue, yeah, I think it's also a hard one because people, I think, are trying not to stigmatize and not to pigeonhole this as, I heard someone say, you know, this isn't a gay disease, this is not an African disease, this is an infectious disease. And to that end, it can affect anyone. And I thought that was a good way of looking at it. On the other hand, like in terms of resources for the medical community, we want to make sure that the right group is getting the attention that they need. Like if we just open vaccine to everyone, then, you know, people who really are at higher risk because they're having more sex, don't get the vaccine, they don't get protected, and then monkeypox has a chance to spread. You know, if we're vaccinating people who like don't leave their house. So I think it is a tricky, like, we want to be open to the idea that this really can affect anyone. And over time, we will probably see it, you know, already there's more cases in women and, you know, a few in children. And if you look at the ages on the CDC, it goes from basically like 2 years old to like 90 something. Like it really is across the spectrum, with the average age being kind of what you would expect. A mobile, you know, like kind of a 35 is the median age. It's a mobile and very social age. So anyway, I'm probably drifting from really answering your question, but I hope that sort of frames it. And yeah, if I haven't answered your question, kind of ask again.
No, that's good. I mean, I didn't expect you to be able to answer what they weren't answering, but you put it in a good framework that I can talk to people about, and that's what I needed. Thank you.
Thanks, Ife. Fabiola, do you want to go?
Yes, thank you. Coming back to the booster, the new booster for COVID, if a person has only the 2 first vaccines for any Pfizer or Moderna, but they didn't want it to take the first and second booster for the past vaccine, are they eligible for this? Can they just do it? Just go straight to this one?
Yep.
Okay.
Yeah, and actually, this is kind of interesting. I saw that they basically are saying like the original vaccine should not be used for boosters anymore. So it's kind of almost like, I don't want to say you can't, because probably somewhere you can, but like essentially they're saying that original vaccine should be for those original 2 doses, or, you know, for immune compromised, it really is a 3-dose primary series. And for little kids, it's a 3-dose primary series. So, but it should be used for the primary series. And then from then on, only use this Omicron booster.
I have a question of my own, Miranda. Do you know if DOH is going to roll out the bivalent vaccine booster like in groups like they did when the vaccine first came out, or is it just going to be open to anyone who wants it right away?
It's going to be open and to anyone who wants it right away. The CDC is kind of saying, and I should just clarify back up, because sometimes we call it the Omicron booster and sometimes we call it the bivalent booster, and those are the same thing. There are actually two versions of it, the Pfizer version and the Moderna version, but they are like kind of literally the same makeup. And again, bivalent, we've talked about the bi is really for 2, original plus Omicron. So, and I kind of flip back and forth in how I'm speaking of them. So the CDC does say, hey, people at highest risk, just like every time we have a new booster, really should get it. But they are not limiting it. Now that could change a little bit when the ACIP meets. They do have the ability to kind of put limits on what the FDA has authorized, but we haven't gotten any signal that that'll be the case. What it probably means is that there's gonna be kind of a logjam at the beginning for people who want it. And so I would say, you know, it's probably gonna take some patience on our part. The shipping, the vaccine is not gonna ship until after Labor Day. And then, you know, everyone kind of needs to get their protocols in place, their people trained up. And so I'm kind of really looking at that next week as being the likely time that, you know, there'll be a goodly number of appointments available. Pharmacies should be doing it, you know, like the CVS, Walgreens, like all the big chains. A lot of our private pharmacies in New Mexico will do it as well. Doctors' offices are kind of ramping up, I think, a little more reluctantly, just because they're busy with everything else. But we did, and then Department of Health, of course, it'll be available. We looked back at who gave the first booster dose, and 55% of doses were done at pharmacies. So really over time, you know, pharmacies have taken on a bigger and bigger role in giving COVID vaccine. And you should be able to go get your flu and your COVID in 2 different arms.
Okay, and just along with this topic, just to be clear, if you have only had the first 2 vaccines and no booster, they can go straight into the new booster?
Yep.
Yes.
Okay.
Yep. I kind of consider it the wipe the slate clean. As long as you've had your first 2 doses, doesn't matter that you missed all those other ones, you're just going to go for this one. And same for the people who have had, like, you know, 2 boosters already. The only thing is there will be a minimum time frame that needs to be to have passed from your last COVID shot. So, you know, some people who, I think a lot of people at this point are waiting, but I went and looked back in New Mexico, about 3,000 doses were given as a second booster in the last 2 weeks. That group of people will need to wait, you know, 2 months or whatever the magic time is to get the new booster. But that's kind of, I think, going to be about the only criteria.
Fabiola?
Yeah, sorry, I have another question with the flu vaccine and all the vaccines. Like the flu comes every year, it changes. If there is a way that they have in place to identify to where the flu is gonna move, like the following year or before the season starts, do they have those parameters and they will be able to do it with COVID in the future?
I think that is the direction it's moving. And interestingly, we were actually talking to Pfizer, and they kind of gave themselves, they feel like from identifying a new variant to production, 100 days, which is that's basically a little over 3 months. And I think that is about what they did for this booster. So what that'll really look like obviously we can't get, you know, the boots on the ground can't get organized to give a new vaccine every 100 days, but it is interesting. The technology does sound like it's pretty fast. And I think the difference with flu is that, you know, it has like kind of once in a year. It has a season that's clear, and with COVID, that pattern hasn't yet emerged. But yes, exactly kind of where you're going with that thought is, I think that will be our future.
And I just want to point out this comment from Sarah in the chat. That's from Debbie Ortiz that says, we are working on a vaccine clinic for our upcoming events. Will there be flu and the new booster available for our county health nurse to get?
Is that Department of Health county nurse? Yes, for sure on the booster. The one thing about flu for Department of Health is we do tend to get our flu vaccine pretty late. So like Walgreens and there's already signs out. Department of Health tends to get it, as I understand, like even into October. So that would be my only hedge on the flu.
Okay, and I see a couple hands raised, and I know we have more questions in the chat. So we can go through the hands and then go back to the chat. Ben, do you want to go?
Thanks, Liesl. Dr. Jerome, we've gotten some occasional questions about a polio vaccine and potential for polio boosters. We've been trying to answer those as they come up, but I thought this might be a good forum to touch base on that. Just to answer the general question, do adults who are already vaccinated, do they need a booster or a polio vaccine? And are there high-risk populations that might want to look into that?
Yeah, good thought. So right now there is not a universal like booster for polio. So if you're an adult and fully vaccinated, you're good to go. Now, sometimes it's hard for adults to know, like depending what age you are, you probably don't have your childhood vaccines into some nifty electronic record that can be accessed. Some, have these, like, I have this kind of almost shredding piece of paper that has my childhood vaccines. So if you are unsure and really can't track down a history, the recommendation is to go ahead and get vaccinated. Or let's say you can see that you got 2, but not the 4 doses recommended. As an adult, you are supposed to, go get those additional doses. And certainly any kids, like that is just so key, trying to get kids caught up. And a lot of kids fell behind just because of COVID and having a hard time getting into into pediatrician offices. So, that would really be a big focus. And I don't, there is no really, so one thing I do encourage everyone, like you can have whatever vaccines you do know that you had, usually you can take them to your doctor's office and have them enter them historically into either their own EHR or the state of New Mexico database, so that they will all kind of be in one place. But yeah, it is, and that's such a great tool. But again, for lots of us who kind of got vaccinated in different places, it's hard to sometimes piece together your own vaccine record.
Thanks, Ben. Zoom user, do you want to go?
Hello?
Hello?
We can hear you.
It's my turn?
Yes.
It's your turn.
I am Dr. Bernal.
Oh,
How are you doing?
Good.
Okay, I have some comments. Let's start with the last one about polio. We have a lot of immigrants and we have a lot of mobility in the population. And as you said, many of them don't have any idea about the status of the polio vaccine. And it's very difficult to track. In children, we have to follow the recommendation of the American Academy of Pediatrics that is use the alternative immunization for children that they are unvaccinated for many reasons, including the COVID. And for adults that they just come and they are immigrants and or they don't have any idea what it is, the vaccination is suggested that they will consider to be vaccinated. That's number one that I read lately. And number two situation is about the monkeypox. As you said, we cannot stigmatize the situation, and we have to use, as you said, very wisely, that take the infection, that take the disease and an infection. And of course, it's not only in one sector of the population, but could be spread everywhere, especially because if somebody has the active lesions, not only in the household, but in any place that there are many people, you can be infected by contact. The bedding, with utensils, restaurants. If you visit somebody who had the active or recently have the active lesions, even the doors, and you can get it. Children are also reported to have, and I saw in the international they have cases, especially in Africa and Europe. Not too many cases, but is present. And one thing that caught my attention was that United States is one of the countries that have many cases of monkeypox. So we have to be vigilant, not stigmatize, and take it as another infection. And probably not exactly the HIV, but we have to have somehow the protocol for that type is a not sexually transmitted disease only, and as somebody mentioned, is body fluids, saliva, tears. So we cannot stigmatize. That's about that. About the Nile virus, we have to consider the world warming, and we have been seeing the presence of vectors, meaning the mosquitoes that transmit the virus. And I saw like a month ago that in the north, like in Pennsylvania, I'm not too sure, I don't want to elaborate in that because I don't remember right now, but it was one case reported. So what we have to do is to follow the instructions that he was given very wisely by Dr. Durham, and also control the water that is collected in places that we don't intend to think that it was by purpose. So is one situation that we have to consider as a possible infection in another states due to the warming. And the third one is about COVID. Due to the morbidity that Omicron, the 45 had, many people are putting attention also. Am I going to have a booster? So finally, it's like an awakening of how to face the endemic situation of coronavirus. Many of them have only one vaccine, and I'm talking about the community and especially the rural areas. Many of them have only 1 or 2 doses, but they are considering the new vaccine, so they can jump immediately to the other one, as Dr. Durham suggests. And the third one is influenza. Last year, in many states, including some of the children, my member family, my grandchildren. Last year they have one was going to surgery, and it was below 16, and they didn't want to do the surgery until he had the COVID. At the same time, the COVID vaccine. At the same time, it was at the end of the year. So in the north, in the Washington area and all the north states, they were giving influenza vaccine at the same time of the COVID. And I think it was by the CDC and the American Academy of Pediatrics and American Family Practice that suggested, especially for the end ages of the society, I mean children and geriatric patients, to have. Last year they received both vaccines at the same time and can be applied in the same arm, not mix it, but you can have it in the same arm. As Dr. Durham said, always in New Mexico we have the vaccine in October, kind of, but in the north right now they are putting already the vaccine for children when they are catching up with immunizations. They are already putting the influenza. So that's were my comments, and I am so glad and honored to hear Dr. Durham on all the wise advice that she had. Thank you so much.
Thank you, Doctor.
Get off mute. Thank you so much. And I all good comments. I definitely wanted to just go back to the monkeypox because I think I did get, but absolutely what you're saying is right. So we talked about kind of the sexual transmission, which really is mostly about that close body to body contact, but also it can pass from saliva. So just those, respiratory droplets, if you're in a confined space with someone for a prolonged period of time without a mask, it can transmit that way. And also through those objects that you were describing. So towels, sheets, bedding, but, surfaces, and how long it lasts on surfaces, we don't know. We know it actually can last for 15 days, up to 15 days on a surface, which is a really long time. But whether it can actually infect someone from that surface during that whole time, that's a little less clear. But for people who have monkeypox and are living with others and trying to stay protected, we do recommend keeping any towels, bedding separate, doing your own laundry. And then if you do have to have shared spaces because you don't have a choice, like in a kitchen, is just making sure you're really wiping down those surfaces. So yeah, great point. Thank you.
And since we're talking about monkeypox, I know that Sarah had a question in the chat about what it means to be high risk for monkeypox. Can you talk about that?
Yeah, so right now, high risk is basically largely men who have sex with men is the high risk population. And within that group, people who have had new sexual partners, in the last month, or multiple sexual partners, that is the main risk group right now.
Sarah, do you have any other questions for Dr. Miranda? Yeah.
Hola, buenas tardes. Quería nada más compartir una persona que acá en el sur de Nuevo México, Carlsbad, Roswell, Artesia, me han comentado, sí, está estigmatizada ya la enfermedad del monkeypox, porque hay algunas personas que me han preguntado si para evitar el contagio de monkeypox necesitan preservativos o condones.
So Sarah wanted to say about how she was accounting a story about someone that she had talked with in New Mexico, close to Roswell, who was talking about how stigmatized monkeypox is and how the only way to kind of to prevent it is through condoms or physical contraception.
Yeah, I mean, unfortunately, condoms alone won't necessarily do it. You know, condoms are good for everything. So they're not good for everything, but they're good for preventing many things. So I've nothing against condoms, but you know, if let's say you are having close body to body contact with someone who has monkeypox in their mouth, you know, and you're kissing that person, a condom doesn't help. I think of it a little bit maybe more like herpes, you know, people who have those cold sores in their mouth, and you know, you kiss someone and you can give them the cold sore. I mean, if you're having oral sex, that it can transmit then to the genital region. But, you know, we've seen monkeypox, they can be anywhere on the body. So definitely, you know, if people have them on their hands and you're holding hands with someone, you can get it. So there's definitely, condoms will help in certain situations, but not all situations. And even if you think you got it from having sex, it isn't always just in the genital area. So, you know, again, we've seen it on the face, and not everyone we've seen really has a good story for getting it in a sexual transmission. You know, I mean, we never know exactly, but there are people who really are like, no, I didn't have sex with anyone in the last 21 days. But, you know, like kind of nightclubby, you know, I haven't been to a nightclub in a long time. So, but, you know, kind of describing really close body to body contact in a very crowded, hot, sweaty setting. So there certainly are other situations that it can come up. And yeah, I've seen monkeypox pretty much any, I mean, scalp, face, mouth, chest, arms, hands, feet, ankles. So anyway, genitals, anus.
Okay, thank you.